Welcome to the Heart Rate Variability Podcast, where we explore the exciting science behind heart rate variability. The material discussed in this podcast should not be taken as medical advice. Please check with your medical provider to make sure any suggestions or strategies are right for you. Visit us at the OptimalHRV.com website to learn more about the Optimal HRV app, download a free copy of Matt's book, Heart Rate Variability, and also get show notes and additional resources around heart rate variability and its applications.
Hi, everyone. Welcome to the Heart Rate Variability Podcast. We've got Matt here, and we've also got our guest who returned, Dr. Richard Gevirtz. Thanks for being back. All right, so we brought him in because we are very interested in learning more about gut-brain health and also how biofeedback plays a role, how HRV plays a role. So I've got a list of questions for you, but at any point, if you kind of want to elaborate or kind of give us some stories of your experience of what got you interested, maybe we could even start with that. So what got you interested in IBS, or let's call it, you said disorders of gut and brain interaction?
Mm-hmm.
What got you interested?
Now they're called, it's a good descriptive, DGBIs. That's the new one, the Rome people. Well, let's see. How did I get interested? I guess because I'm good friends with a pediatric gastroenterologist, and we knew that the gut was heavily influenced by the autonomic nervous system, especially the vagus. And so we said a logical, since we were working on disorders of autonomic dysfunction, we thought a logical one might be this one. And the first kid he sent me, we got better in about 3 weeks completely.
Wow.
That was just lucky. But so then I thought, boy, this is cool. So then we started cultivating. My friend Warren got me introduced at our children's hospital, Rady's Children's Hospital here, to do some in-services for the pediatric gastroenterologist. And the reinforcing part of this is that gastroenterologists totally get the brain-gut interaction. This is a very big part of their training. So it's a very receptive audience. You do not have to convince them. And about 40% of the kids that they see have these functional disorders, and they have no treatment for it. These are probably about 70% female, lovely physicians. They love kids. They're just lovely people. They're not full of themselves like surgeons are. And so they feel terrible when they couldn't help the kid, right? So, and these tend to be internalizing kids that are kind of internalizing emotions, and so they're adorable kids. And I love kids. I've always loved kids. I was a camp counselor when I was a teenager for all my years, and I've always been a kid person. So it was just sort of natural that we got into it.
Awesome, cool. So what would you say in terms of the role of HRV? What can we kind of expect to see for baseline HRV for individuals with these types of conditions?
Yeah, so we do a 5-minute resting baseline with breathing normally, and there's lots of studies showing that they have poor vagal tone, poor variability in general, especially vagal tone, RMSSD and LNHF. But it does vary a lot. So in the clinic, we always take the baseline first. We're kind of hoping that we're going to see some low numbers, because that sort of justifies what we're doing and makes a real easy explanation. We don't always see that. Sometimes the kids look pretty normal to start with. So I run a clinic. I have 2 interns. We see about 14, 15 sessions a week, 20 sessions a week, and probably 80% of those are kids or adolescents with these problems. So we get a lot of experience with it. And we have to be open-minded. So some of them come in with nice-looking HRV, but in general, you're getting RMSSDs in the 30s and STNNs in the 30s or 20s, and LNHF in mid fives. So that makes it real easy for the explanation, because we can just go right into our psychoeducation explaining how dominant the vagus is in controlling the gut, and that their vagal tone is not really doing what it's supposed to. And it gives us the opportunity to talk about the main model we have is vagal withdrawal being the main model. Unlike trauma, this is a disorder that doesn't seem to be associated with big sympathetic surges with that kind of stress. In general, these are kids that are just kind of worriers, anxious, and they don't. So they're sort of taking the brake off too much. We actually have one study where we did that with an ambulatory device. We did put it on the kids for a day of school called a life shirt. It's a cute little shirt for the kids. The kids liked it. They could open it up and be Superman, because it's like a latex shirt. And then we got basically every heartbeat and every breath for a day of school. And then my poor grad students had to go through 5 minute by 5 minute by 5 minute of the day. This shirt also had an accelerometer. So we were looking for periods of time when they're sitting quietly, breathing normally. And then we would take our numbers from that, and we ended up getting really good, reliable numbers before treatment and then after treatment. So the kids started off with lower vagal tone and numbers to start with than the normal kids. And then they improved during the treatment, during biofeedback. And the big thing was, and this was a big finding, there was a really strong correlation between the gain in vagal tone and the reduction of symptoms, like a 0.68 or 0.65 correlation. So those kids that had the most improvement from the biofeedback also had the most improvement in their symptoms. They all were improved, but that was and that study actually won a prize at American College of Gastroenterology, because it's a mechanism study, right? Which they love. They don't love studies they can't figure out. But this was giving them a mechanism they understood, so they loved it. And we did publish it. It's Eric Sauder's study, SOWDER.
Very cool. I'd love to throw in a question here, Anna, if it's okay. You started me out like I consider myself, because of the connection between the gut and the brain, I'm fascinated with gut health. My work in trauma, and this may be like, you mentioned that the patient population was probably not experiencing trauma, though we do see a lot of what I used to call irritable bowel syndrome, before you dropped that bomb on us here a little earlier with the new name.
Well, they still call it irritable bowel syndrome. That's just part of the DGBIs. So.
But I love the fact we're bringing the brain in there, that real connection piece. So, are we thinking with that name change? I just wonder, sort of, as name tweak, maybe better.
Umbrella term.
The umbrella term.
Yeah.
Have you seen a movement over the years towards that? I mean, there's some fascinating science around gut health, mental health, the connections, neurons, serotonin, etc. But I'd love to just maybe update for folks like me that didn't know that this has gone maybe more into the diagnostic level of labels, sort of what's happened recently to make this connection that powerful.
Yeah, well, so the anatomy and physiology has been known for centuries, and the gastroenterologists sort of get it, but just the prevalence of these disorders, both with, we don't see so many of the trauma ones, you might see them, but it could also occur in those populations, of course. And so that part, I think, is pretty established science. I don't think you would find very many gastroenterologists that wouldn't kind of just acknowledge that stress plays an important role in IBS, not IBD, but IBS. The newer stuff is the microbiome. which is way more complicated and way more controversial. So the original study that was really exciting found that in animals, if you cut the vagal afferent in animals from the biome to the brain, that you lose the brain-gut connection with the depression. So the thinking was that's where depression is coming from the vagal afferent. If there's like a bacterial overgrowth or a bad microbiome. But the trouble was it was lost in translation. It didn't seem to work in humans. So we don't really know, and the microbiome is exquisitely complicated. The number of organisms in the gut, everybody's different, are in the millions of different organisms. So you get people who get better with antibiotics and people get worse with antibiotics.
Yeah.
And probiotics have been a bust. They don't really work very well, but for some people they do. And I think it's just a shot. You take a shot with a probiotic, maybe you get it. Most times you don't. Most everybody I've known who's spent a lot of money on probiotics have got no effect from it at all. So that's the area that we will see some growth in. There's a lot of interest in that. You've heard about fecal transplants for people with C. difficile. So there's one microbiome that we do know. We really know what that bacterial is, and it's horrible. It can kill you. So there's those kinds of things. But beyond that, we don't know too much more about that part of it. But from our point of view, almost every kid, adolescent, adult we see has tried changing their diet, changing probiotics, going gluten-free, going dairy-free, going fructose-free, and we're seeing them because that didn't work. They're a little better when they went gluten-free, maybe 4% better. And they're a little better all of us have a little tougher time with gluten and dairy. If you don't have celiac, though, it's probably not a major factor. So we're really, the kids we see are really thrilled to be able to go back and eat pizza again. So.
Yeah, I remember something from your class. You would talk about how these kids were not able to go to sleepovers. They couldn't go to camping events just because staying overnight somewhere was just their worst nightmare if they don't know where the bathroom is or if they're worried about having an episode. And then that anxiety itself perpetuated it, right?
Right.
And I loved hearing in your class how these kids were just so excited because they got to go to a sleepover, right? Or they were able to go on that summer camping trip with their Boy Scout group or Girl Scout group. And I think that's really cool.
And they could eat pizza, Anna. Pizza. Like, can you imagine how much you would love your physician at this age if you could eat pizza and then you go for a treatment and you could eat pizza? I just had to throw that one in too.
Right.
Yeah, it's tough on kids not to be able to eat pizza. Right?
Yeah, it's tough. Yeah.
Definitely. And so like what I was wondering is when you see a child and you see adults for DGBI related conditions too, right?
Yeah, fewer, but yeah.
Okay. Is part of your intake, do you assess for diet and like nutrition and okay.
Yeah, we do, but they've already been through this. They've already seen a dietitian when we see them. And
okay.
they're kind of discouraged already by that. So, we assess for exercise, sleep, diet, all these lifestyle things. But it turns out, they matter, but not that much. Lately, we have been getting a lot more referrals from there's a clinic at UCSD that specializes in reflux and GERD. And so there's a real cool study out of England showing that esophageal pain thresholds are totally related to vagal tone. I don't remember those studies on it from the class, but so this was quite an experience. I was doing a workshop in London, and these are all psychologists, psychiatrists, therapists, that come to these workshops, biofeedback people, and go around the room. And there's this one guy, his name is Claude Bota, and he says, "So yeah, I'm Claude Bota. I'm a postdoc at the Neurogastro and Enterological Institute at Bart University here in London. I said, what is neurogastroenterology? And he said, well, we study, mostly they study reflux. And they have these amazing studies, and he had read my work, so that's why I came to the workshop, where they put a nasal gastric tube down into the esophagus, and they put some little electrodes on it that can warm up slowly, and you can then rate the beginning, just the very beginnings of pain in the esophagus. You get an esophageal pain threshold, which, because it's thing when they spell it with an O, so it's OTS. And it turns out that most of us have very stable esophageal pain thresholds. The one thing that affects it is acid in the gut. So this tube, then they pour a bunch of acid in the gut and the pain thresholds go down 30%. So the same stimulus that was not even perceived before, when there's a bunch of acid in the gut, suddenly is super sensitive to pain. So I thought, well, that's interesting in itself. And the relationship is related to vagal tone. So then they got the idea is let's teach people HRV biofeedback and see what happens to this. I never knew about this until this workshop. And he said, yeah, so we did that. We taught them to breathe at about 6 per minute. And then we did this thing again, and it completely overrode the acid lowering of the threshold. In other words, once they were breathing anywhere near 6 per minute, the threshold was unaffected by acid. So that tells you how powerful that, and they did it, and it correlated strongly with what they had a cool thing called a neuroscope, which is a fancy thing of bars that just translates vagal tone into a little bar graph. So you could see when the bar graph was up, they didn't feel the pain. When the bar graph was down, they did feel the pain.
Wow. So
yeah, it was just super cool. Like I learned so much in that workshop compared to what I taught. It was great. So, and I've kept up with that group. The head of the group is a guy named Aziz in East London. It so happens that their lab is like 4 blocks away from my nephew, where my nephew lives in Shoreditch in London. So, but I've never been able to get him to respond until I go visit him. But anyway, so.
Let me throw, if I could, a lay person's question in here, because I think, you know, both of you obviously carry a huge amount of expertise in this area, but I would imagine maybe a few of our listeners are like, okay, I probably know enough about heart rate variability, stress response, maybe a little bit about that, how that relates to gut health, but is really breathing practice, biofeedback, that powerful? I mean, just the results you're getting. So the answer is obviously yes, but I wonder if you could maybe fill in the blanks for some of our people like me who don't claim the expertise you do. Is how is fairly simple breathing practices having these amazing clinical results?
Yeah, so the gut has an internal control system, the enteric nervous system, which is like 10 to the 9th neurons. It's the brain in itself. But the external control is the vagus completely. The only role that the sympathetic has is to shut the gut down dramatically, right? So in the face of a real threat, sympathetic threat, then the gut, we don't need to be digesting our Big Macs if there's a saber-tooth tiger out there. So, so it shuts the gut down completely. But we don't think that is a common occurrence in everyday life. So then it turns out, if we kind of look at the data, that what you need to keep the gut healthy is a pretty steady stream of vagal braking. Remember from the last one, that's when you breathe in, the brake goes off, and the brake goes on. And when there's enough intervening vagal braking, it actually supplies serotonin to the enteric nervous system. 95% of the body's serotonin's in the gut, only 5% in the brain. So it's keeping that healthy neurotransmitter in the enteric nervous system, which doesn't make the system sensitive to stretch. So when you lose that regulation in the gut is only sensitive to stretch and to burning. So if suddenly your thresholds are way down because just a little stretch makes it hurt, that could be where abdominal pain comes from. And all it takes is enough vagal withdrawal to break off enough times of the day to make the gut much more sensitive to the pain. And so we know that regular practice of resonance frequency breathing improves, if people do practice 10 minutes or more a day, then it improves vagal tone by about 25% over about 5 weeks. And that's pretty consistent finding in most studies we do.
Fascinating.
If you're improving that vagal tone, this is resting vagal tone, not just during breathing. This is when you're not breathing slowly. So we have 2-3 studies in our lab, and other labs have got the same thing. So now what you're doing is kind of putting in that little missing element into the gut that keeps it regulated. And if it stays regulated for 3, 4, 5 weeks, then suddenly stretch becomes stretch. It doesn't become pain anymore. Things move through in the proper sequence. So diarrhea becomes normalized, constipation becomes normalized. Because part of that gut's role is to, peristalsis is to knead all of that, the contents, get rid of the fluids, take the nutrients out. Goes through too fast, it's diarrhea. Goes through slow, it's constipation. And so the cases that are the easiest to convince them is if they have constipation related pain and then they have a bowel movement that feels better, it totally fits with a stretch model, right? Say, well, evacuated the stretch in your gut, and so that it doesn't hurt anymore. They say, oh, no wonder that feels better. Fortunately, that's not true for everybody, but when it is true, it's like, yes, we got that explanation.
That's awesome. Andy, you got any more questions? Good.
Yeah, so I was gonna ask, for someone who's listening to this and maybe they're exploring doing biofeedback, or maybe they're interested in kind of even just providing psychoeducation to a patient, referring them to someone that does HRV biofeedback, what would be something important maybe that they should know, or maybe rule out, or just kind of some considerations if they're looking for some help, how they can get connected to someone who does this type of work? So I know for a lot of times you'll see HRV biofeedback therapists like really talk about anxiety a lot, but you don't see a lot of them talk about DGBI related conditions. So I'm wondering if there's like a way to kind of connect that bridge, or even just kind of some thoughts of hope to kind of provide for them.
Yeah, for children and adolescents, if you're in a metropolitan area, you need to see a university-based, children's hospital-based gastroenterologist. And in most areas that we've kind of corresponded with, Children's Hospital of Pennsylvania, our Rady's Hospital, CHOC Children's Hospital of Orange County, LA Children's Hospital, Seattle, Chicago, trained a lot of people. So generally, Chicago especially, there's a whole big psychological group that does nothing, but they're associated with North Shore Health in Chicago. In fact, one of our former students, Alice Reynard, works in that particular unit. So she's a gastroenterological psychologist. So
Cool.
There are many of those. So anyway, for those people, I would say, if you've got your local pediatrician, fine. They may not know about this, but if you get to a teaching hospital somewhere, gastroenterologists, pediatric gastroenterologists, they may know somebody. Nationwide, Rainbow, Cincinnati, those are all hospitals I know do that. They have referral sources where they'll send out somebody for HRV biofeedback. So those are the ones. For adults, it's tougher. The adult gastroenterologists kind of get it, but they don't typically refer as much. And I'm not sure what I would do with that, but just go to BCIA website and see if you can find somebody who does HRV biofeedback. It should be helpful.
Yeah. Awesome. And if their aim is kind of to help more with like anxiety, that will essentially give them the same benefits if they do a similar protocol.
Yeah. So the two improve a lot. So the Beck, we give them Beck anxiety inventories. They improve a lot on those. There's already a couple of meta-analyses on anxiety for HRV biofeedback. So we have really pretty good evidence that it produces pretty good anxiolytic responses in people.
Awesome.
But there are a lot of people with IBS that don't identify as anxiety patients. So
that is so true. I was talking to a family member of mine who goes, so my doctor says I have irritable bowel syndrome. And I was like, oh, you must be like struggling with stress or something. And she goes, well, that must not be it then. Because I think sometimes when people hear it's something that's lifestyle induced or, psychophysiologically involved, it can be like, oh, well, I might have to like change some, things I'm doing in my life. I might have to change how essentially breathing, right? Any words like of encouragement for someone? Because I know sometimes going to biofeedback, hearing you need to do it for 5 weeks, what kind of success stories have you seen or heard? Or that you've witnessed,
Yeah, well, we witness them every day, but one of our students did a 28 consecutive case series study, which we published. So and those are kids and adolescents, and they varied from IBS to other kinds of similar problems. Some with abdominal pain, some with constipation. So out of the 28 were improved. 70% were symptom-free, and 30% were greatly improved.
Wow.
Some good results.
Those are very good results. Now, lately we've been getting sent much more problematic cases with all kinds of other diseases too. And so we're not always as successful as that. But if it's a pretty straightforward, the intern comes in and does the case history for me, and it's a kid that meets all the criteria. They don't have to be stressed necessarily, but they often are. But this is where that idea of vagal withdrawal is a powerful, for the therapist listening, it really is something you need to think about. Read Steve Porges's paper on vagal withdrawal. It changes the way you think about stress. So instead of thinking about stress as accelerator, as a fight-flight response, you start seeing your client you're talking about, Anna, would probably be able to identify periods of time that she had a lot of aggravation or just didn't feel good or something that could be enough time to take the brake off the gut. And so we often don't get self-reported stress. We often do, but often we don't. So that idea of vagal withdrawal, to me, was one of the most powerful, in my talk therapy, it was one of the most powerful ideas that I ever came across. I was trained with all about sympathetic, right? It was all sympathetic. In our early days of biofeedback, when we had skin conductance and finger temperature and EMG, so we were just calming down sympathetic activity, which wasn't working that great. So as soon as I got this idea, it changed everything the way I thought. It also led me to ACT too, because ACT is a perfect, acceptance and commitment therapy is a perfect fit for that vagal withdrawal idea. So.
Would you be able to expand briefly on that, on what you mean by how it fits well?
Yeah, well, you guys ever talk about ACT on this podcast?
Not in detail.
So you got to get Ina on here and get an hour on ACT from her. So ACT is an alternative to CBT that changes the role a little bit. Instead of changing and challenging dysfunctional cognitions, you learn acceptance strategies and commitment and get away from experiential avoidance. So you're learning how to not struggle with your anxiety as opposed to try to challenge your anxiety. And that's just a perfect fit for that vagal withdrawal idea, right? Yeah. So if you're saying, the problem for you is that you're in vagal withdrawal too many hours a day. And how does that happen is because, the finger, give them all these Chinese finger puzzles. So we say, the harder you pull, the tighter it gets, right? So if you're struggling with your anxiety 3 hours a day, you can bet your vagal brake is off. And if your vagal brake is off, you don't have to identify that as stress, but that's making your gut sick. So that usually works pretty well with people. They sort of get that we're not accusing them of being neurotic or being,
Right.
Air traffic controllers or cops or something that they think that's what stress is. This is like, you know, saber-tooth husbands, children, wives, traffic, co-workers. Those are the vagal withdrawal folks.
Yeah. And in the trauma world, ACT is very popular. Seems like a really good fit for a lot of folks with that. I'd love to ask kind of a nerd question following up. When we talk about vagal withdrawal, I would love to connect. We were sort of having a nerdy discussion about dorsal vagal activation before we hit record here. But like vagal withdrawal, I'd love to get a little specific here. So obviously, respiratory sinus arrhythmia. Sorry, it's a little late in the day. I'll get my words right here. The exhale, the brake goes on. Inhale, brake goes off. So when we talk about withdrawal, are we maybe a little bit more specifically? Help me understand, because I imagine it's still going on the exhale, but not as much.
Maybe not braking at all.
Okay, so
in the extreme, you get the brake goes off completely.
Yeah, that would be more. Would that be more fight flight sort of energy? Not necessarily. Okay.
Not necessarily. It's hard to separate the two when you get
Yeah.
to but those combinations, what you'll see is higher, flatter heart rate.
Okay.
And you all of the rhythm and the heart rate's gone. That's all ventral vagal. There's nothing to do with the dorsal.
Yeah.
So basically, that breaking with breath of the heart is part of our healthy restorative response to the body in many ways, not just in the gut.
Yeah.
If the brake is turned off, and there's a vulnerable organ system, be it anxiety, be it the brain or the gut or muscles or whatever, you'll see it show up there.
Great. Thank you.
The way I kind of describe it to patients, and correct me if I'm wrong here, is I kind of tell them it's like having if that brake is never implemented or used, or even just like kept in use to maintain it, it gets rusty, and the moment you need it, it doesn't work. And so it's almost like it's to the point where you can't even press it down. And that can both be for,
especially if their baseline levels are consistent with that, then you really got a good argument for them, right? So someone comes in with a 15 SDNN and a 12 RMSSD, their brake is really rusted and not working.
Yeah.
So you say, well, the good news is you've got a lot of things you can improve. The bad news is that your heart's almost a metronome, and that's not good for you. So.
Yeah.
Right. Definitely.
I love, Anna, what you said, because I'm a huge, especially with children, Carol Dweck's work on growth mindset, and it's another kind of muscle that we're exercising, which I know my wife has had a lot of success teaching neurobiology to first and second graders by using that sort of muscle analogy in there, and to hear you doing it in your clinical work, it's like, oh, we could throw all Dweck's work in there too with that. Whenever you can put Dweck in, it's always a good day for me.
Yeah, I think it's a good analogy actually to like resistance training for a muscle, right? You want to get a muscle stronger, you almost damage the muscle, right? And then it heals better than it was. So in this case, we're making these big peaks and valleys of your heart rate, so really taking the baroreflex to its limits. And why exactly that wires better, but it does. The analogy is it's like exercise for your autonomic nervous system, which we use that a lot.
Yeah.
Definitely. Would you suggest, kind of going back to these DGBI conditions, do you find it's more helpful for people to do the breathing when they're having symptoms or not, or both? Both,
yeah. So what we do is we first get them trained up, so they're doing really good, getting big, smooth peaks and valleys, a single low frequency peak, as good as they can get it. And then we start instructing them to do this rescue breathing version of that. So in the session, what we do is we stress them and then say, okay, go. and they go back in their breathing, and we count how many breaths it takes to get them back into that rhythm. And we say, okay, well, we know, oftentimes I look at the finger temperature, right? So I'm saying it took you 6 breaths before your hand temperature start going back up again. So that's how long it takes you to kind of turn that ship for you. Some people could be quicker, some people may be longer. So then once they get that idea, then they use it both ways. They use it when they're needed, but they have to keep practicing daily.
Right.
But we did a follow-up, kind of phone call follow-up with the kids in that Souter study. And at first they said, oh yes, we practice every day. And then we sort of asked the parents, and they said, no, not really. And then we said, what really do you do? And said, well, whenever they need it, they practice again.
Yeah. That's the hardest part, is the adherence, right? And then I've been told by supervisors too that, we don't want them to only do it when they're stressed, because then it becomes paired with stress. And the idea is that it can be like brushing your teeth, like it's part of like a daily routine, like exercise. You don't do it just because your teeth are dirty, you brush your teeth. You do it every day because it's good for your teeth.
That's first.
But I think sometimes it's challenging for like the motivation part.
Yeah, it's very challenging. Yeah, you remember Jason Liu? So Jason just finished the study, which we're just sending him publication like tomorrow, I think, in Taiwan, where he was treating traumatic brain injury with HRV biofeedback.
Awesome.
A couple of unique things to it. One, Jason is all over it, so he was talking to these people regularly. And number two, they're Taiwanese, so they do what they're told. So these people really practiced, and we saw the most amazing results in the study. Every measure, every neuropsych measure, every psychological measure, HRV measure, we had a control group, a psychoeducational control group, that didn't improve on anything. And this group had better neuropsych memory functions, every neuropsych measure was greatly improved, almost all to normal.
Wow.
But one of the things that we could really see in the HRV improvement was, I said, well, Jason, how did you get them to practice? He said, well, they knew they needed to practice. Right? It's like a cultural thing, right? And so he was sure that these people practiced every day. And we rarely see that in our culture, right? So this is like, oh God, so great we can get them to practice. So.
You do have pizza as a motivator, though. If all else fails, you can maybe bring a pizza in and say, we'll heat this back up for you if you practice.
Yeah.
Well, I think that study is going to be so helpful to show, because I think a lot of patients go, oh, I'll just do it 5 minutes, like a couple days a week, and then they think they're going to get the results. But if there's like results that show, hey, when people actually did it like this, they got these outcomes. I had a patient today who even said, because I was telling him he was struggling with kind of like some like fatigue and like a little drowsiness. And I asked him to start doing some controlled breathing just to help improve attention and focus. And he said, yeah, I'm not going to just do some breath work for that, and that's an attest to that, right? Like it's, it kind of shows that, it's going to increase blood flow to areas of the brain that are responsible for increasing attention and focus. And we see that even just in mindfulness meditation too. So I feel validated as a therapist. And two, I think that is something we want to try to talk about too, because not only is it going to help with his cognitive functioning, but it's also going to just continue, if he doesn't even have any, gut health problems like we were talking about, keeping that not a problem.
Yeah, for sure.
Well, and I kind of mentioned Carol's work around growth mindset. I think one of the difficult things with adherence to like biofeedback, I was preaching mindfulness, but before by biofeedback, now I'm obsessed with getting everybody on it. But it's like you talked about going to the gym. You might do a couple of sets of curls. Your biceps aren't gonna bulge out of your shirt right away. So I think it's sometimes how we talk about it, because with mindfulness, it's like this mystical thing, and you will levitate after 2 minutes of your first practice. And it's like,
Yeah.
No, I mean, it's been life-changing for me, but I've been doing it now for 15 years. And you don't need to do it for 15 years to get a lot of the benefits. But I think we're in such that immediate benefit kind of culture that it's like, thinking about it as a muscle gives folks an analogy to say, okay, I know if I go to the gym every day or every other day, I will get bigger biceps, but not just from one, quick workout. And so I've been working with folks, this is where my motivational interview and cognitive behavioral background comes in, is how do we really frame some of this really hard work that you don't get, so you're giving up something and you're not getting something immediately. And that's the hardest thing to get people excited about, is like, okay, I'm giving up 10 minutes of my day. I'm not feeling better the day after I did it. Like, yeah, you got at least do it for a week. But, it's, I think, a challenge on us to, how do we frame this in a way that picks up that adherence?
It's probably the major challenge facing our field. So whatever we can do.
Awesome.
Yeah, definitely. But we're getting there. And I mean, I think what's cool with the technology aspect is we're having more ways to track, and people can monitor on their phones. They can log when they practice, or different programs where you can see if they're currently training. So that part's cool, because I know the substance abuse one, I remember that one was tricky knowing if they were actually practicing, right? Because it's like they could say whatever they want to, right? And there's that wanting to please the PI or the therapist too. And so I usually tell patients, I'm like, look, I would rather you just be honest about how many you did, because then I can kind of assess like what we need to do differently. If I don't know what's going on, I can't really help as accurately. But I think a lot of it is just, us modeling it too. I just told Matt in our group that I'm going to start doing HRV biofeedback with myself, because I tanked in my HRV a couple weeks ago and it scared me.
Yeah.
And so, we got to practice what we preach and understand where it is challenging to keep doing that. But those are all the
it's kind of funny, just as a side note, is one of the things that I thought was really important, and this goes back to when we were just tracking heart rate variability, doing 3-minute readings before we got Ina's work into our app, is something folks loved is that we have a provider dashboard so that they can actually see whether or not you really did practice. And that seems to just that idea that my practitioner is there tracking me, and I kind of can't come in and lie about it. We're getting a lot of feedback from practitioners that's sort of been a game changer around adherence, which.
Yeah, and it's been a while. It's been hard to convince the clinicians to do these baseline readings very often, but I think you're absolutely right. I had somebody this morning who's got POTS, and she has improved her RMSSD from 12 to 55.
Wow. Oh, wow.
Like 300% change. So, and her symptoms are better, but not completely gone. But that was very reinforcing for her to see those numbers. And I even did a recheck on it to see. So, I mean, I think that we try to use that as much as we can. And in fact, with the kids, if they're not improving, we usually are pretty sure they're not practicing.
Then there's that. Yeah.
When you got the data and the studies to reach that conclusion, that's amazing. That's
Well, as Anna said, the technology is getting there. So now Mo, one of our students, is doing a study with an ambulatory follow-up after we see them in the clinic here. They're going to wear for 2 weeks, the leaf for 2 weeks, and we'll actually be able to see, because it records everything.
Yeah.
We'll be able to see how much that practice relates to their changes in symptoms. So that'll be interesting.
Right. Awesome. I look forward to what y'all find out. That's all I have for questions. Matt, do you have any more for Dr. Gevirtz?
Finally on one of my podcasts, the guest brought up fecal transplant and I didn't. So this is great. I think I brought it up in my podcast I've done like 80 times, because there's a 13-year-old boy that lives inside of me, and I just find it fascinating that taking other people's poop can make our gut health better. But so I just appreciate you bringing it up, because usually I'm the one that's bringing up fecal transplants in less scientifically appropriate ways, but appreciate it. And just appreciate you joining us again. You always have a home here on the Heart Rate Variability Podcast, because I just feel like I get a semester's worth of material in 60 minutes from you, whether I'm in your workshops at a conference or we're lucky enough to have you on the guest. So we'll put some contact information again in the show notes that you can find at optimalhrv.com. And I just want to thank our guests for joining us, and thank you to our guests. And Anna, great job hosting your first podcast. So hopefully the first of many. You did a great job.
Thanks, everyone. Hope it wasn't too brutal.
He's the Oprah of the future.
I love that. The Oprah.
That's
of
a
the
big
future.
compliment. Holy moly. Day made.
Take care, everybody.